notes, first just to run through a list of things for you not to forget. First of all, thank you to our sponsors for their support of this 2018 ANZICS meeting. We'd appreciate your assistance in reducing distractions by checking your cell phone is switched to silent during the sessions. We'd ask you not to film speakers unless you have prior permission. If you're not already done so, visit the registration desk to select your seat at the gala dinner. Very, very important. For any nursing staff, please note that the ACCN AGM has been moved from Hall C to E1, that's this room, this afternoon. Don't forget to complete your exhibition passport and return your entry to the registration desk. I don't actually know what the prize is. Tonight's party, the Friday night party, will take place at the National Wine Centre from 7:30. Buses will depart from outside the Convention Centre on North Terrace at 7 p.m. Return trips from 9:30 to 11:45. Please take note of your nearest exit, and in the event of an emergency, please follow the instructions of the Convention Centre staff. And at any time, if you need any assistance, see the conference company team at the registration desk. So we'll get on with the first presentation.
Okay, so our first speaker is Laurent Bitcar. He's a French intensivist with a background in nephrology and respiratory medicine, currently completing a fellowship in intensive care research at the Austin Hospital in Melbourne, as well as a PhD through the Université de Lyon. Apologies for my poor pronunciation. Laurent is going to be speaking about performance of urinary cell cycle arrest biomarkers for the prediction of acute kidney injury in critically ill patients. Thank you.
Thank you very much. Watch. Green button? No. It's the first one. Yeah. Not that one.
Uh-oh.
No.
Uh-oh.
Okay. I uploaded it.
No. Did you loaded it up?
Yeah, I did. And it did
should
work.
we maybe jump to the next speaker and you can go sort it out, or are you able to sort it out now?
Yes.
Oh, wonderful.
Perfect. Thank you very much. So thank you very much for giving me the opportunity to present some of the work we did here at the Austin in Melbourne. So why do we need to predict acute kidney injury? First, acute kidney injury is a frequent syndrome that we see in 30% of our patients. It's associated with an increased mortality. And as you know, acute kidney injury is defined on functional parameters, mainly urine output and increase in serum creatinine. But unfortunately, once we observe those increase, in fact, it's already too late, and the patient has already lost 50% of his renal function. So why would it be important to predict the occurrence, the incidence of acute kidney injury? Then if we could have early detection, then maybe we could start looking into intervention that may alter the course or change the course of acute kidney injury. Because so far, what we do is just keep calm and prepare the filter. So the first method to predict AKI is to use the most recently developed and validated urinary biomarkers for acute kidney injury. Those are TIMP2 and IGFBP7. Those are two peptides measured in the urine. And they're called, when associated, they give you a score, and it's commercialized under the name of NephroCheck. Those two proteins are part of the cell cycle, and they are increased when the cell stops its cycle. It's secreted mainly by the proximal tubule, and when elevated in the urine of a critically ill patient, it has demonstrated a very good and excellent predictive performance to predict acute kidney injury within 12 hours of the urinary spot sample. That was published in 2013. It's called the SAPPHIRE study, and it's a reference paper in this field. The other idea is not to use those recently developed novel biomarkers, but maybe to use conventional ones we already have available. The idea behind this is that if we look at creatinine and urine output over a short period of time, I don't see the point of it. if we looked at the changes in urine output and creatinine over a short period of time and see that, for example, creatinine increases over 6 hours, maybe we could then predict acute kidney injury if it followed the same trend. So our hypothesis and objective is to assess how those novel biomarkers work in our cohort, in our Australian patients, and then compare it to those conventional biomarkers that haven't been looked at in this way. So we did a prospective single-center study at the Austin Hospital in the Department of Intensive Care. We recruited 2 cohorts of patients, but all results were analyzed as one cohort. So one group of patients was included based on AKI high risk of AKI, and the other one was the other patients were included following the exact inclusion criteria of the Sapphire cohort, trying to reproduce their results. We excluded all patients with known AKI stage 2 and 3 at the time of urine sampling, and then we collected those informations. So first, we collected urine at time 0 and measured in the urine the 2 NephroCheck proteins. We also measured urinary creatinine because we wanted to see how correcting NephroCheck value for urinary creatinine, as it should be recommended, as it is recommended, how it would perform if we corrected it for urinary creatinine. We also looked at the 6 hours preceding our urinary sample and looked over those 6 hours at the urine output of the patient and the change in creatinine between 2 measurements over 6 hours. And then at 12 hours, we assessed our main outcome, and that was acute kidney injury stage 2 and 3, as per KDIGO guidelines. So we so far have enrolled 96 patients, of which 32 developed acute kidney injury stage 2 and 3. There was no difference between the 2 group of patients, apart from higher weight in the acute kidney injury patients and a higher serum creatinine at the time of enrollment. Comparing the novel biomarkers, the NephroCheck was significantly higher in patients who will go into acute kidney injury, but not if you took NephroCheck corrected to urinary creatinine. Looking at the conventional values of biomarkers, the values of conventional biomarkers, we see that urine output was already lower in patients who will go into AKI. Serum creatinine was already more elevated in patients who will go into AKI. And then this renal score at the bottom line, I will talk a bit more about this afterwards. So this is the relationship between the AKI severity and the NephroCheck values. So there is this beautiful exponential relationship between AKI severity and NephroCheck values. There is some outliers in patients who didn't go into AKI, but still had high NephroCheck values in the urine. Urine output over 6 hours was significantly lower the more you go into more severe stages of acute kidney injury, and the change in serum creatinine was more important in patients that will go into more severe stages of acute kidney injury. We then, based on the previous slide, we then calculated a renal score based on the ratio of the change in creatinine divided by the urine output, both assessed over the 6 hours before the urine sampling. And so making the assumption that the more the score will go up, the more the risk will be important. And we have another beautiful exponential relationship between AKI severity and the value of this score, okay? Then we compare the AUCs of all those biomarkers. So first, we confirmed that the NephroCheck performed relatively well with an AUC of 0.72. And we also observed that the conventional biomarkers were performing in the same range of AUCs. There was no significant difference between the AUCs of conventional biomarkers and the NephroCheck. But by combining those two, using the renal score and the NephroCheck, we had an AUC of 0.8 and a net reclassification index of 0.8. So a very good predictive performance of the association of both tests. So in our single-center cohort, we confirmed the performance of NephroCheck to predict acute kidney injury within 12 hours of urine sampling. The AUC was 0.72, slightly lower than what was published in the Sapphire cohort, but maybe mainly related to difference in populations. Also, we observed that patients without acute kidney injury had elevated NEPHROCHECK values in the urine. This has been previously discussed in the literature, but so far no one really knows what this means. It may be that those patients had tubular stress or renal stress, but went into injury. But because we still lack a gold standard to evaluate tubular stress, we don't really know yet. And then we were really surprised to see that NEPHROCHECK corrected to urinary creatinine performed really badly in a not good way, and we still don't know why. Maybe because NEPHROCHECK urine values or levels are dependent on the outputs, on the urine output and urine concentration. Regarding conventional biomarkers, they may be equivalent to the novel, more recent developed biomarkers. What is really important to note is that their performance will be highly dependent on the time frame over which you will assess them. Okay? If it's a short time frame, your prediction performance will be less, but the longer this time frame would be, the more the prediction will be good. But at some point, you won't be predicting anymore, but you will be diagnosing AKI. The perspective would be to first explore why urine concentration has such a negative effect on the predictive performance of NEPHROCHECK. Then maybe see how NEPHROCHECK and our conventional biomarkers perform in different subgroup population and see if some patient may benefit more from that kind of prediction. So what we've observed is that conventional and novel AKI biomarkers have shown an equivalent performance for the prediction of acute kidney injury within 12 hours. We're really excited about those results because we think that implementing them in our daily practice may help us predict the short-term incidence of acute kidney injury and then maybe drive the design or study of novel interventions that may potentially alter the course of acute kidney injury. Thank you for your attention.
Area under the receiver-operator curve is not intuitively obvious to me. Do you have any information on the sensitivity and specificity of those two approaches?
So the NEPHROCHECK, when it was implemented, they gave you two cutoff values that would have a high sensitivity,
yep,
and the other one would have a high specificity. So we didn't discuss those thresholds. We'll measure them and we'll give in the paper we'll give the results, but we won't be trying to manipulate those. On the other part, renal score, the best value was a value of 3. It's an absolute value. It doesn't mean much on itself, and it has like a specificity of around 0.7 and a sensitivity of 0.7 and a specificity of 0.75. So quite a good predictive value. That may be, again, dependent on the time frame over which, again, all of those parameters were measured over 6 hours, maybe shorter term, may not perform as well at all.
And with the model, I noticed you had quite a few diabetics in the study. Did you have any information on baseline proteinuria? Was that something that you looked at?
No, I don't have the information about proteinuria. That would be a very interesting thing. What I know is that diabetes patient didn't drive the results or modify the results in any way, but something we should keep an eye on.
All right. In the interest of time, we better move on, but thank you very much, Laurent. It's excellent talk.